Hello, everyone. I am Vic Jagger with Magic 102.3 and 92.7 and Urban One, and welcome to Your Health Matters. Take control over prostate cancer. So we are excited to get into this conversation, and we have a group of experts who are ready to answer all of your questions and give you information that you need, important information. So without further ado, let's get to the panel. We have Dr. Otis Brawley, who's a medical oncologist, a globally recognized expert in cancer prevention and control. Welcome.
Thank you for having me.
We also have Dr. DeVille Jr. Dr. DeVille, a radiation oncologist who is the medical director of the Johns Hopkins Proton Therapy Center, clinical director of radiation oncology at Sibley Memorial Hospital, and co-director of the Kimmel Cancer Center Prostate Multidisciplinary Clinic. Welcome.
Thanks for having me as well. Thank you.
Yes, thank you for being here. And last but not least, we have Dr. Zachary Hughes, who's a primary care provider. He is the office medical director of JHCP Sibley Primary Care, specializing in internal medicine. Welcome.
Thanks, Vic, for having me.
All right. So let's talk about prostate cancer. And so I'll begin with Otis and Kurt. And we're going to talk about the overall cancer and risk reduction. So let's start with just the basics. How does cancer develop? And we'll start with you, Dr. Brawley.
Well, cancer is uncontrolled cell growth where one cell becomes 2, becomes 4, becomes 8, and it just keeps going on. Prostate cancer starts in the prostate, which is a gland which is located down in the pelvis. It's below the bladder. And we don't know exactly why prostate cancer starts. We know that it is incredibly common. It's incredibly common in Black men and white men and all men. As we age, it gets to be very, very common. It does tend to be more common in men who are from Northwest Sub-Saharan Africa. Not all Black men, but Black men who originate from the area of Ghana and Nigeria, Cameroon.
And Kurt, can you talk about the risk factors for prostate cancer, lung cancer, colon cancer? Can you give us that overview?
Yeah, some cancers we know have clear sort of cause or association with sort of what is the cause. Lung cancer is a good example of that, with the risk of smoking and development of that uncontrolled cell growth that Dr. Brawley mentioned, those mutations that lead to that. Other cancers like prostate cancer, we're not entirely clear as sort of on the specific cause of why one gets prostate cancer. In fact, the most common scenario is someone who sort of has no family history and sort of no clear reason. We do know certain risk factors, though, for example, so that helps us to guide. And as we'll talk about screening and how we sort of try to get to early detection. And so there are certain risk factors, age in particular. So it's a cancer of older age is rare, sort of under age 40 is pretty rare, and the average age of diagnosis is in the 60s. And there are other risk factors, as Dr. Brawley mentioned, race, sort of a West African origin, Black men in the United States in particular having higher rates than most men globally, in fact. There are other risk factors for other types of cancers, like viruses, for example. We hear about cervical cancer and HPV. And other types of cancers now that we're better understanding that are HPV related, like head and neck cancers and those sorts of things. So there's a wide variety of things that may be risk factors, but for many cancers, we actually don't understand what are the specific risks.
And, Dr. Brawley, you were talking about, the specific regions and things where men are more likely to develop prostate cancer. So Black and African-American men are at greater risk than other men for developing cancer. Can you expound on that?
Yeah, the vast majority of Black men in the United States are actually in the Western world, including South America, are, because of the slave trade, from Northwest Sub-Saharan Africa, that area where there is a higher rate of prostate cancer.
Okay. And let's talk about reducing risk of prostate, lung, and colon cancer. Can you both kind of give your opinion on that?
Well, it's easier to talk about reducing risk of lung cancer.
Mhm.
80% of people who develop lung cancer are smokers. And so if people don't smoke, don't start smoking. If you do smoke, please try to stop, try to get help to stop smoking. That lowers risk of getting lung cancer. And people who, if a 40-year-old stops smoking, their risk of lung cancer goes down dramatically over the next 10 years. So you can actually do something to lower risk of lung cancer. With colon cancer, we know that people who have diets that are high in fiber, especially vegetarian diets, have a lower risk of getting colon cancer. We also know that in the case of people who smoke a lot or have smoked a lot in the past, when they get into their early 50s, lung cancer screening with spiral CT can save lives. We know that colon cancer screening, which should start at about the age of 45 in normal risk people, not only can save lives, but colon cancer screening uniquely can actually prevent colon cancer by finding some pre-cancerous lesions and removing those pre-cancerous lesions. And Kurt, what have I forgotten to talk about?
I mean, I would just add for prostate cancer specifically, we talk about diet and exercise, a lot in terms of, the historically, I always tell patients that the American diet that's historically been high in red meat and saturated fat, has not done us well. That, leads to higher rates of prostate cancer in men and breast cancer in women. And so we hear a lot of these days about the Mediterranean diet. So having a diet that has less red meat, may have fish or lean meats. And for prostate cancer, also we think about the cruciferous vegetables, kale, collards. Those things tend to be, sort of protective. And nowadays we're hearing a lot about plant-based diets. So as Dr. Barlow mentioned, that for colorectal cancer, in general for prostate cancer, there's more and more data coming out telling us the good thing is it's not all or none. I do, it's hard for me to cut back on meat, so I can relate to patients and folks. But so the more that you can introduce higher amounts of plants, plant products, fruits and vegetables, basically in your diet, and reducing the red meat can be helpful to reduce the risk for prostate cancer.
In the United States, and we've gotten a lot of press recently about alcohol and cancer. I should point out the number one cause of cancer in the United States, causing more than 20% of all cancers, is tobacco use. Number two is actually excess caloric intake, eating too much, not exercising that caloric energy off, and then storing that caloric energy. And with storage of caloric energy, we call obesity. So eating too many calories, not exercising enough, and then storing those calories as obesity is the second leading cause of cancer in the United States. And the third leading cause of cancer in the United States is actually alcohol.
Wow. Which I did not know. So thank you for that. I had a question about, when we talk about tobacco use and cancer, there are many myths out there when it comes to smoking. And now with the use of people are smoking more cannabis as well. Can you break down, the people who say, well, I don't smoke cigarettes, so I shouldn't be high risk, but they're smoking hookah or they're vaping, and then maybe the misinformation with cannabis linked to the overall smoking conversation. Can you kind of break that down and give us the facts on that?
I'll go there.
Okay.
There are 80 known carcinogens in tobacco. Now, when you talk about marijuana, a good 60 of those 80 carcinogens are in marijuana. So you are inhaling or ingesting things that are chemicals known to cause cancer when using marijuana. Now, the one thing about marijuana, that's different from tobacco is most people who smoke about 20 to 40 cigarettes a day. Most people who smoke marijuana do not consume as much carcinogen on a daily basis as with tobacco. When we start talking about vaping, in my world, we refer to vaping as safer than smoking tobacco, but we don't say it is safe. There's a difference between being safer and being safe. Many of the vape formulas actually have in them uh, uh, radiator fluid, the antifreeze. And I just can't think it's really healthy to inhale antifreeze.
Wow.
Yeah.
Again, did not know that. I don't vape, but
Yeah.
I mean, I know that it's popular. So just to hear that. So we have a question in our queue. Does stress play a role in cancer risk? Either of you can take that.
I think so, but I don't know. What do you think, Kurt?
No, I agree. I don't think there's great data, very clear data, I should say, that tells us, sort of direct cause and effect in relation to cancer. But I agree. I don't think it's helping probably much in terms of how cancer develops. So.
Yeah, it may be such things as people who are stressed eat more, have more obesity, that sort of thing. It may be more like that, but I know a lot of, I know tobacco causes 18 different kinds of cancer. I know that energy imbalance, that's eating too many calories, not doing enough exercise, and being fat causes 12 different kinds of cancer. But the studies to tell us that stress itself causes cancer, it's not really there.
I mean,
that's not to say it doesn't cause cancer.
Yeah. The other way I answer this question sometimes is that I think people that are, very busy, stressful lives, they may often be delaying their regular routine care and screening and physical. How many times you hear that somebody missed their annual physical, and we see it on the end where, okay, now they have their diagnosis is a little bit further along and maybe could have been caught earlier. It's because they got, 100 other things going on and not focusing on their own health, not, putting that as high on the priority list. So that's why I think stress can also kind of be a negative here.
Okay, so let's move on to men and prostate cancer and the difficult conversations that may surround that, where men are afraid to bring it up. Can you talk about reasons why they may be afraid to bring it up, and what do men specifically need to know about prostate cancer?
I can start a little bit, but Zach, you probably see it. You're seeing a lot of men here in their physicals and their screening and that sort of thing. But I think just to add on to the last piece I was answering, at least that's what I hear. I'm further downstream as a radiation oncologist. By the time the patient sees me, they're diagnosed with their cancer. We're at the sort of treatment and management phase. But what I hear, I'm often asking, were you being screened? Were you having checkups? Was blood work being checked? These sorts of things. And hearing about, some of the stigma, some of just the concern, being afraid of some of the testing and those sorts of pieces. But I know Zach is earlier on on the front lines of having these conversations with men.
Yeah, I mean, I think I can get things started. I think Dr. Brawley may be able to mop up kind of the last bits there with some more technical data. But, we would put prostate cancer, I believe, as the second most common cancer in men currently. And there are some regional distributions to that throughout the United States that maybe are different. So I guess point there being that it's common. The second point, I think, on it, though, from a prevention detection standpoint that I'm involved in, is that the testing to screen for the prostate cancer is very complicated. And you could say, oh, it's just a blood test at this point. But the interpretation is where it gets really messy. And so it really requires an individualized approach of assessing someone's underlying risks, and the weighing those against the potential benefits of detecting a cancer early, the prostate cancer early, versus the potential medical harms that can occur from either false positives or false negatives. So this to get at this question and to make proper health choices around this, we really have to have a one-on-one conversation about between me and then you as a patient to determine what's right for you.
That is so true. There is this movement afoot to do screening on buses and supermarket parking lots or at churches on Sunday that scare me, quite honestly, because when you look at the professional organizations, be it the American Cancer Society or the U.S. Service Task Force, none of them say men should be screened starting at age 45. They say within the physician-patient relationship, where a physician and a patient know each other, a man needs to be informed of the potential risks and the potential benefits of screening and go through this conversation that Zach is talking about.
Now, Dr. Brawley, can you talk about signs or symptoms, warning signs of prostate cancer that men can look for?
Sure. As men old, many of us, our prostates get larger, and as our prostates get larger, we urinate through the prostate, and the tube that we urinate through gets squeezed down as the prostate gets bigger. It's, the donut analogy is a donut in the oven rises and gets bigger, the hole in the middle gets smaller. So we have difficulty urinating. Now, that's not necessarily prostate cancer. That's benign. It's actually called benign prostatic hyperplasia. It's got benign in the name. But many of us get that. And it is reason why we should be assessed for prostate cancer. Again, for most of us, it's a benign process, but it's something we should talk to our doctor about and get an assessment for prostate cancer. Some of us may also start having urinary tract infections. We will have difficulty emptying our bladder. Less likely, but occasionally we will hear people who have blood in their urine or blood in their ejaculate. Those men need to go see a doctor and talk to the doctor about evaluation. And those are the usual signs of a localized prostate cancer. Occasionally, when a man has really bad prostate cancer, it will spread to the bone or to other organs, and it can cause pain and other things. And gentlemen, have I forgotten anything?
No, I mean, I would add that, the thing I tell patients a lot of times, nowadays men are diagnosed often through the screening, the blood test that Zach mentioned. And so they don't present with symptoms. So it's sort of just to emphasize, you should not sit around waiting for symptoms. You should be, seeing your doctor, getting your annual physical, having that conversation, asking the questions, what are we testing for? What cancers are we testing for and looking for? And that usually if we have waited for symptoms from cancer, we have waited too long. So we're, there are symptoms that men may still present with, and there are some men that may have the blood test checked, but have actual cancer in the gland. And some men are sort of low, we call them low PSA producers. So the test is not the be all end all. Some men may present in other ways, but very often, we're trying to catch it early so they're not presenting with symptoms.
And that's what I was going to ask. I know that there may be a little anxiety around testing and rumors that, men may have heard about how, the testing is done. Can you kind of walk us through like what someone would experience if it's their first time doing testing for prostate cancer? What would you say to ease that anxiety around the process?
Zach deals with that all the time.
Well, so the current recommended screening, if it's recommended for you as an individual, once we go through that kind of risk benefit analysis, is a blood test. So, inserting a needle into a blood vessel drawing out that tube of blood and sending it to the lab. For most patients, that's relatively inconsequential, would already be done for other reasons as part of their annual preventative screening to check on other things like kidney health, your cholesterol perhaps, and other forms of organ function and cell count. So no additional invasiveness beyond what would already be occurring. I know that many men's fear around this is maybe more historical at this point, and for many, many years, decades, we did an annual digital rectal exam, meaning we, as physicians, put our finger up someone's anus and felt the prostate itself. And that's a cause for great embarrassment for many men, as well as discomfort in some cases, or pain. That is no longer recommended as a form of screening at the level of primary care doctors. That may be needed in other circumstances, but it's not part of prostate cancer screening.
Thank you for that. So let's talk about Dr. Brawley. How does DC compare to the rest of the U.S. in terms of prostate cancer incidence, mortality, et cetera?
Yeah. DC has a large proportion of the men who live in DC are Black. And as a result, DC has a very high rate of prostate cancer. And it's one of the reasons why we need to have this conversation, and men need to decide what they want to do. Now, I will tell you, and this is an argument for screening and early detection, that if a man is found to be stage 2, his prognosis is the same, be he Black or white or other, as long as he gets optimal, good, high quality care. So equal treatment yields equal outcome in terms of stage of disease, as long as we can get the man high quality care. So what I'm saying is, while Black men are more likely to have the disease, once diagnosed, their prognosis is the same as white men when they have high quality care. Now, I can tell you nationally, and this is what I do academic studies on, a large number of Black men do not get that high quality care we're talking about.
Yeah, and it's so important that we advocate for that. Dr. Hughes, can you talk again about the importance of having a relationship with your doctor and having conversations about screenings and just having tough conversations in general? Because a lot of times, men may be hesitant. And I know you probably approach it in various ways, but can you talk about the importance of that relationship and just being transparent with your physician?
This is really a huge question, so jump back in if I get lost in it. But I mean, I think if you break it down on its surface, this is really the medical equivalent of asking why is it important to have a best friend, right? So what I think break it down for as the first idea, everybody's a little bit different, and so we all have different ideas of what healthy looks like and what our health goals are. And so me as a physician, I have specific health ideas. Maybe me as a private person, if you came to my house, would have slightly different health ideas. And those would be different from my siblings or partner or, parents, etc. And so the relationship that I develop with my patients in the primary care setting over time allows me to understand you as a person and what matters to you, right? And that informs not just the discussion around cancer screening, but a variety of health priorities that we might be tackling over time. The other element is that when you have a relationship with a physician, they are no longer thinking about you just in this particular moment. Part of my job is to think about you and what our relationship will be in 10 years, 20 years, and maybe the provider that will come after me when you're 40 years older than you currently are. And so I'm trying to take care of you in all of those instances at the same time. And so that allows us to kind of change the way we're interacting there. It's not quite as transactional as it might appear otherwise on the surface. So, and having that kind of trust and long-term relationship really opens up this possibility of talking about some of the embarrassing and serious things that we need to go into, because over time you'll learn that I'm interested in you as a person, in your health, and I'm trying to really be an objective third party that can remind you of the things that you might have wanted to sweep under the rug with your spouse or from some other friends that are out there, but that could be symptoms of serious conditions, or it could just, by doing some small things like upping those fruits and vegetables or the time on the treadmill, you could reap massive benefits over the course of 20 years. So I think that's the crux of it.
Well said. So we have a question from Dina Lancy watching on YouTube. Can the doctors explain what the stages of prostate cancer are?
I can take
the
that.
staging experts in medicine are radiation oncology.
I jumped right in. I mentioned, so that's part of our job. So by the time, and I really appreciated Zach's comments of building the bond and the relationship and gaining trust, and that's really what we're working on as well. Because by the time we get to the patient and they're choosing between their treatment options, and we're going to talk about how those treatment options can affect very personal and private things like urination and erections and bowel function, and so you really do need to have a good relationship, be able to talk and confide with your physician and feel comfortable with them. But so staging relates to all that, and that we need to understand staging is a way for us to classify and categorize the cancer, and explain whether it is still localized or it has moved regionally to say adjacent lymph nodes, or if it's moved more distantly to what we call metastasis or metastatic disease. And for prostate cancer, it likes to go to the bone or the lymph node before it goes anywhere else. So that's usually what we're talking about in terms of metastasis. And stage 1 is generally a very early stage, unaggressive, minimally aggressive, localized prostate cancer, which for many men may be able to just be monitored. We hear about the term active surveillance or active monitoring. So it's a program usually between the urologist and the patient where they're going to set up serial monitoring of that blood test of the PSA, and periodic maybe imaging, including an MRI and potentially a biopsy, say annually or at some regular intervals, to kind of check in on the cancer, make sure it's not starting to become more aggressive where it then needs treatment. So in that case, if we're following that patient at a stage 1, maybe their biopsy 2 or 3 years down the road has now progressed to a stage 2, in that the way we categorize the biopsy cells, we call the Gleason score. Their Gleason score might be increasing. And so usually that's stage 2 patients are what we classify as kind of intermediate risk. Again, it's still in the early stage. Their outcomes are still very good. It's not spread distantly. They have very high cure rates. Once we get into stage 3, it's usually what we call high risk patients. So those patients have higher Gleason scores. The cells, when we look under the microscope, tell us they're behaving more aggressively. We see a lot more, their potential for, they're dividing very quickly. Their potential to spread seems more obvious, or that potential is there. They're still potentially curative. It's just that, the rates of cure may be lower than, say, someone in a stage 2 or stage 1 situation. And then stage 4 is the final stage. All cancers are generally classified as a sort of 4 at 4 stages. 4 usually always means it's metastasized, it's spread. And for prostate cancer, if it's spread to even just a single lymph node, it's classified as stage 4. Or if it's spread kind of widespread throughout the body. But there's clearly a range there in how we treat patients and how we manage patients. If they have limited sites of spread, or if they have many sites of spread, they may be treated similarly or differently. But those are the general stages for prostate cancer. And really, we use it to help decide on what is the appropriate management for them also.
This is a good place to point out that many men who are stage 1, early stage, with what's called low Gleason score are great candidates to be watched. And indeed, 20 years ago, every man who was diagnosed with prostate cancer, we said they need to start treatment within the next 2 weeks. Now, literally 60%, more than half of men who have this low stage cancer have low Gleason score, and their first therapy is observation. And the majority of those men who we are watching will never need to get definitive treatment.
Now, is there a reason for that? Why, can you kind of explain why it's an observation rather than you need to go get treatment?
Okay, well, prostate cancer, think of prostate cancer the way we think of cats. There are cats that you might have in your home as your pet, and there are lions and tigers out there. Okay, I find some prostate cancers that are very tame and very non-aggressive, and the treatment is worse than anything we can do to them. Then I find some of these prostate cancers that are very aggressive, and if we don't intervene and treat, the man is going to not do well.
Okay.
And I think it's an important point. I like the analogy of the cats, because I do often see, you hear from patients very often, oh, I've heard prostate cancer is unaggressive, it's very indolent, I don't have to do anything. And sometimes we say, that's not the type of prostate cancer you have. Yes, prostate cancer can be that way. So, we're trying to chase them down because we don't want them to have the bad outcomes and the higher death rates and those sorts of things, and let them know that that's not this type of prostate cancer. And on the flip side, yes, sometimes it is hard to just reassure men, yes, it is okay to actually observe your cancer. We said the C word, but it is actually okay to monitor and observe your cancer and to delay and defer treatment as long as possible. Those kind of concepts sometimes are hard for folks to really get.
All right, so let's talk about, advocacy and the important messages that you would like our audience to know. Maybe we missed some things, or there's just some points that you want to make clear or that you want to reiterate. But we can start with you, Dr. Brawley.
Well, I think, number one, I have run into a number of men, not just Black men, by the way, who have difficulty urinating, difficulty getting a stream going. They're getting up and having to go to the bathroom several times every night because they can't empty their bladder because they have prostate problems. And those men are afraid to go to the doctor and say, I have a prostate problem. They're afraid that they're going to go down the road of being evaluated for prostate cancer and other things. I want to encourage those men who have those symptoms to go to the doctor, number one. That's one thing. Number two, I would love for every man to have a relationship with a primary care doc like Zach, where they can talk about prostate cancer questions or issues, as well as other things. We're talking about prostate cancer tonight, but keep in mind, more men are going to die from lung cancer than die from prostate cancer, and more men are going to die from cardiovascular disease due to hypertension and diabetes than die from lung cancer. So let's think about the whole man. And so I want to encourage men to go to doctors and have a good conversation about your health, prostate cancer and otherwise.
Absolutely. Because what, I wanted to say this as well. We're seeing a lot of men, Black men specifically, who are dying from, heart attacks, from cancer, and from different things that are preventative, like that you can prevent. So can you just talk about like the age range and kind of where men need to be, with asking questions, with certain screenings, that you deem are important for men to know? Because a lot of times they're like, oh, I'm not sick, so I don't need to go to the doctor.
Zach, can you talk about hypertension and diabetes and those sorts of things?
Uh, you know, I wish I could tell you there was an age where you don't need to have a doctor. You can just be free out there, you know.
Not just
But the
just living life.
but you know, I think the reality that we live in, and in the American culture, the food system that we possess, our cultural values around exercise and how we build cities and drive and all this, the infrastructure, um, really brings in a lot of risks for us. In a myriad of different health conditions. We just heard about hypertension, maybe hyperlipidemia, which is high cholesterol. And we've been talking about cancer this whole time. But there really are recommendations for screening specific item healthcare risks at all ages. And so a routine check-in is a good idea. The frequency of those check-ins does vary, however, across the age spectrum, and the risk factors that an individual possesses, and that all has to be taken into account together in a discussion with the doctor to figure out how often should you be seen, how often you should be screened, and for what at this phase of your life. But yeah, even people in their 18 to 27 range, who we normally think are basically invincible, have screening opportunities that have personal impact as well as public health implications for society at large. So, you know,
you just mentioned 18-year-olds. You know, human papillomavirus vaccine, which we're now starting to give to kids who are 11 and 12 years old, we can still get some young folks who are in their 20s to catch up and get HPV vaccine. It prevents cervical cancer. It actually prevents head and neck cancer and a few other cancers as well.
Yeah, I mean, we're doing even more than that, I'd say, at this point. You know, we are catching people up to age 45. I had my series 2 years ago, you know.
So we have a question on the Facebook page from Pamela Goetz, sorry, excuse me. What are some ways that men can reduce their risk for prostate cancer? And I know we went over this, but listen, we got to do it again as many times as
Well, I spoke a little bit earlier about the diet and exercise piece, or you know, sort of moving away from our old school American diet that's high in red meat and saturated fat, and having more of a plant-based diet, or we hear about the Mediterranean diet, sort of, you know, little red meat, more lean meats or fish, the cruciferous vegetables, kale, collard, those sorts of things. Lycopene, selenium, so tomato, watermelon. There's, you know, really, I think we asked before about resources. One resource that I like to point patients to is the Prostate Cancer Foundation, pcf.org. So kind of largest philanthropic organization in the world, actually, in terms of raising money for prostate cancer research. They have great evidence-based, you know, good information, validated information, and for patients, particularly on diet and wellness, there are some good links there. So if people are interested, at cookbooks and recipes and things like that, that kind of go over this information. So that's one way. And higher levels of exercise, Dr. Brawley mentioned, you know, just that equation of, you know, how much you're eating and what's your output, your exercise. So there are studies that show higher levels of exercise. We used to say 90 minutes a week, which I would think of as sort of 30 minutes 3 times a week. But there was a study showed higher levels, so 150 minutes. So like 5 sessions of 30 minutes. So if you like long hikes on the weekend or something like that, higher levels of exercise were associated with lower rates of prostate cancer recurrence. We talked about smoking before. We don't think smoking causes prostate cancer, but it definitely, in men who are diagnosed with prostate cancer, they tend to have higher risk, so more advanced prostate cancer. And so it is still worth, if you're a smoker and diagnosed with prostate cancer, to stop smoking, or if you're don't have prostate cancer, still stop smoking for all the other benefits that we talked about before. Those are a few. You guys might have some more to add.
No, you hit it real well. There's a joke in our world. You know, there's a study that shows that men who eat high amounts of cooked tomato products, there's a correlation with a lower risk of prostate cancer. Now, correlation does not necessarily mean causation, but when I was young, I took that as reason why I could eat pizza.
That's a good reason, right? So, Dr. DeVille, do you have any important messages that you want to share with our audience that you would like them to know that maybe we didn't cover or that you want to reiterate?
Yeah, I think another piece, as I was thinking about websites and information, find good sources, good, evidence, not the Dr. Google negative, down the rabbit hole, but what are sort of
Because
really—
you're going to have so many symptoms. Listen,
Yeah.
I am guilty. I will Google some symptoms and I would be diagnosed with so much stuff. I'm like, I need to go to the ER because the internet is saying that I have 24 hours.
Yeah.
Yeah.
And especially once one has, is diagnosed with cancer, I see a lot, patients may be overwhelmed with trying to find, good sources of information. Obviously, we're all from Hopkins and, there's great information on the Hopkins website.
Absolutely.
But also like for the NCCN guidelines, if we think about what are standards of care, sometimes I see patients and they say, this was offered to me, that was offered to me. They don't sort of know, how do I know what is an appropriate, what standard of care? So it's NCCN, National Cancer Comprehensive Network, nccn.org is kind of the consortium of cancer centers that puts out the national guidelines that every single type of cancer, every year, those are sort of updated. And that's a good source. It's translated for physicians. It has it for lay people, sort of general public. That's a good resource. Ultimately back to that, have that good relationship with your physician, be able to ask the questions. If you're not comfortable, get a second opinion, get a third opinion, have a comfort level, be able to ask the questions of, as simple as they may be, as we're talking about surgery and radiation and focal therapies and all these treatments that we might have. It can, again, feel overwhelming, and being able to kind of pause and, really confide and feel comfortable with your doctor, I think is most important. So that you can feel, afterwards that you can, feel comfortable with the recommendations that are being made and these treatments that you might need to receive.
So we have a couple of questions here from YouTube. What about risk of pesticides and prostate cancer?
I'm the epidemiologist. I'll handle that one. We do not have good studies to correlate prostate cancer risk with exposure to pesticides. Most of the cancers that are linked to certain pesticides are lymphomas, which are cancer of the lymph system. For prostate cancer, men who work in the tanning industry, like leather tanning, men who work in heavy metal industries, especially battery making industries, do seem to have a higher amount of prostate cancer or higher risk of prostate cancer. We've never been able to exactly pin a cause. We can just say men who work in battery manufacturing plants have a higher risk of prostate cancer. Agent Orange exposure in Vietnam has been politically, it is definitely linked to prostate cancer. In the academic world, we actually wonder if it's that Vietnam veterans tend to go to the doctor more and tend to get screened more compared to veterans who were in Europe at that time. So there's some question in the medical world, does Agent Orange cause prostate cancer? But any man who has prostate cancer who served in Vietnam should go see the Veterans Administration, because they will compensate him and provide him with free medical care.
Great information.
And I just plug in on that as well. I think it brings it underneath the direct question that was asked. It brings up kind of an important element on the whole concept of having a long-standing relationship with someone in the medical field. And so I'd say that this idea of what exposures do you have, what chemicals have you maybe experienced exposure to in your life, what is your exposure to radiation been like in your life, is something that we would address in an annual physical in many cases. including kind of broadening that question out to what is your occupation, knowing that some exposures are more likely. And while they may not all be linked to cancer, they may be linked to other screenable conditions.
That's a good point.
Thank you for that. So we have another question from Facebook to One Up Barnes. Okay, so I'm gonna put my doctor hat on and see if because I think I have this right. What are your thoughts of having a simple, is it prostatectomy? Did I say it right, guys?
Yeah.
Or a larger prostate. I had to tackle that word. Okay, so one of the doctors.
I could take that one. I would assume, so they're saying a simple prostatectomy. So prostatectomy is surgical removal of the prostate. And so the question, thoughts on having a simple prostatectomy for
simple versus radical, I think, Kurt.
So simple would be a partial removal.
Yeah, exactly. So usually when we use the term, like for cancer surgery, we would refer to as a radical prostatectomy. So usually a urologist would perform this. None of us are urologists, but we certainly see many patients that have these types of procedures. And that, if we think about, we would call it an oncologic resection. Usually for cancer, you need to get wide margins. You know, there's sort of the visible tumor, if it is visible, and then there's sort of those cells that may be microscopically sort of moving further along. So there are, you know, sort of standard procedures that are done to ensure that you have wide, clear margins. Of course, that may be associated with more risks and side effects and those sorts of things, but you want to make sure you get all the cancer, the visible and the sort of microscopic. The macroscopic and the microscopic, we would say. So simple prostatectomy may often refer to like a non-cancer procedure, which is what Dr. Brawley was talking about before with that BPH, with that benign prostate enlargement. There are a variety of procedures that can be done. You can do some resection of the prostate that would be, you know, probably called a simple prostatectomy is probably the most removal of the prostate. But I think that's what they might be referring to. It's sort of a non-standard cancer procedure. That would not be considered in a cancer procedure. Go ahead.
Yeah. Now, for men who do have benign prostatic hyperplasia, the swollen prostate, the simple prostatectomy is probably, I would suspect, the most aggressive treatment that you could have for really bad prostatism, is what it's called. Other men, we give drugs that strengthen the bladder so that they can actually create a stronger stream urinating. We have several drugs that actually shrink the prostate, and when you shrink the prostate, the hole in the middle gets bigger. Some of those drugs, by the way, have been tested over time to see if they prevent prostate cancer. There's a mixed bag there. None of them are FDA approved for preventing prostate cancer, but there are a number of medical procedures and some other surgical procedures before you get the simple prostatectomy that we can use to help men who are having difficulty urinating. But when it's really bad, you have to go to the simple prostatectomy.
All right, so we have another question from YouTube. What advice do you have for men who may feel uncertain or fearful about staying on active surveillance instead of starting treatment?
Yeah, so these are often patients I might see, you know, as a radiation oncologist. They're sort of deciding whether to stay on surveillance or move on. You know, the word fearful there is the one that kind of sticks out. I think, you know, we should be making informed decisions. So the question is, you know, how are we addressing all of their questions and concerns? There are some percentage of men that may decide that they no longer want to do surveillance and move on to treatment. Usually we're using the triggers that I mentioned before. Is their Gleason score increasing, kind of the way we score the tissues? Are we seeing the cancer cells behaving more aggressively? Are we just seeing a lot more cancer being detected in the prostate gland? Maybe they had 2 or 3 biopsy cores involved, and now they have 8 or 10. We're seeing a higher volume of cancer. So we have certain triggers that might, you know, then we make a recommendation for the patient to move on to treatment that we see the cancer behaving more aggressively. This sounds like it may be the scenario where the patient, we're not seeing those features, but they are, for whatever reason, maybe tired of being on active surveillance. Or sometimes I hear patients had a family member, they have a friend that, you know, died from prostate cancer. They have a certain story or something that is kind of compelling them to to move on to treatment. We have additional tools. We have what's called genomic testing. We can test the genes of the tumor to see how they're behaving, if they're behaving aggressively. So, not knowing the full scenario, I would want to really explore that with the patient to see sort of what are the drivers. Is there any additional workup we could do to assure them that it still appears safe to monitor their cancer? But there may be other factors that still compel them. I see sometimes patients, they've had repeated biopsy. They may have an infection, a complication from the biopsy. They have other things that they felt were sort of worse than just proceeding on to treatment and finally want to move on. So it can get a little bit complicated, but really sorting through that to figure out, is it appropriate? Is it safe to watch? Or are you ready for which reason to move on to treatment?
The area where I find patients have more difficulty is when we first diagnose them and we come up with this, we should watch you, we should not treat you. We've for over 100 years been saying the way to deal with every cancer is to find it early and cut it out. And now here's this doctor saying there's such a thing as a good cancer. And so it's one of the reasons why I like to have this discussion about observation before we have the discussion about screening and treatment, because if the man is diagnosed, I don't want him to be surprised with the idea that we're going to watch his cancer. There's actually one study that's looked at a large number of men, and over a 20-year period of time of men who started out being observed, 20% got treated because their tumor was progressing. 20% got treated because they couldn't take being watched anymore. And 60% were still being watched at 20 years.
So I think that gets back to that idea we referenced before of, your idea of health is different from person to person, right? And so we come into this medical situation with in this case, prostate cancer, with a lot of other baggage that we're bringing in, and we have to explore all that together. And we wouldn't, as physicians, offer active surveillance, this watchful modality rather than treatment, if we believe that it was putting you at risk. And we're weighing the potential benefits of those treatments against the potential harms. So there are side effects, there are consequences, which may not be experienced by all men that undergo treatment, but some will have.
All right, one more question from YouTube. Wallace Lindsay writes, what determines the treatment for radiation therapy versus proton therapy?
I know our time is limited. Otherwise, I could an hour. I would just a sort of quick version. So radiation can be a good, option for patients. Radiation is sort of the overall category. There are multiple forms of radiation that we can actually use to treat prostate cancer. There's internal or external radiation. Internal radiation is technically called brachytherapy, but sometimes people have heard of prostate seed implant. That is a form of radiation that gets implanted in the body and sort of kills the cancer cells and decays over time. And it's actually been around for a long time and can be effective for certain types of prostate cancer. More commonly, men will get external radiation, which is really just like x-rays. If you've had an x-ray or a CAT scan, you're lying on a flat table and the machine's doing all the work, you're just laying there. Rather than for an x-ray, you use a low dose to take a broad image to sort of see things. For radiation therapy for treatment, we're using a high dose to a focal area. So we're targeting the prostate to kill the cancer within the gland. And then within that external radiation, we can use X-ray radiation, which is called photons, or we can use proton therapy. Proton therapy is a little bit more niche. There's only like 40 some proton centers in the country. And so most men are going to get X-ray or photon therapy for their treatment. There's thousands of linear accelerators in the country. Protons has some properties that can be, have an advantage. There's no exit dose into the surrounding tissues. So both are equally effective at eliminating the cancer. But protons may expose less of the bladder, the rectum in kind of a low dose range. No one's yet proven that that has less side effects. In fact, there's some early data that's come out that showed both did equally as well. One was not better than the other in terms of having a better side effect profile. So the bottom line, to kind of answer the person's question, usually it's a matter of access, where you're located. Are you near a proton center? Also insurance, I usually tell the patient, is a big driver. Some insurers won't cover it because we don't have large long-term studies showing that there's any advantage that protons are actually better, and they are more costly to deliver than the standard X-rays. So we're still waiting for some of that data to mature from two large national trials that have been completed in a head-to-head fashion. But mostly, again, back to our original conversation, you see a radiation oncologist, the patient's going to have a conversation, really lay out what forms of radiation are you a candidate for. Sometimes I tell the patient, we're not going to end this conversation by saying this one treatment is better for you. We may say you have a menu of options that at the end of the day, all of these are good options for you and you should do well. And it's really having that conversation, back to what we talked about, that shared decision-making approach, to hear what are their values, what are they preferring, are they interested in internal treatment or not? Do they favor a more external approach? Or maybe it's not any radiation, it's more of a surgical end that they favor, and making sure they're a good candidate, a suitable candidate for whatever treatments are available.
Yes, there are options, and I'm glad that you guys laid it out as much as you could, because I'm sure there are many, many more options and avenues available. But as we wrap up the conversation, I just want to go through with all three of you any messages that you would like to share with our audience, and any websites that you would recommend for information on prostate and other cancers. Dr. Brawley, we'll start with you.
Yeah. My favorite website's the American Cancer Society at cancer.org, and the National Cancer Institute at cancer.gov. So those two. I just hope all men will think about health and think about establishing a relationship with a doctor, a primary care doc, to talk about their health and focus on all the various issues, prostate and others.
Dr. DeVille?
Well, I mentioned a few websites, so
you did, yes.
Let them quickly: the Prostate Cancer Foundation, nccn.org, our Hopkins website. The other thing I'll plug that I think didn't necessarily come up was multidisciplinary clinics for cancer care. Many institutions have those. Hopkins has it. I usually encourage patients, it's perfectly fine to get a second opinion if you start at another, facility or center. Most physicians should encourage that. I would say go to a reputable place that, has high volume and experience in the type of cancer that you might be diagnosed with, because that's, going to matter and make a difference. And multidisciplinary clinics, what they are essentially, I call it kind of a one-stop shop. You'll often have a radiation oncologist, medical oncologist for the case of prostate cancer, urologist. You'll have often the imaging specialist or radiologist, the pathologist in real time, kind of reviewing the individual's case. And it's been shown that, patients have better outcomes when they go through these experiences, not just in terms of like their cancer outcomes, but we reduce costs, we're more efficient, because the physicians are also all together discussing the case in real time. And hopefully the patient can get some more reassurance rather than having to sort of go from one place to the next place to the next place and trying to sort of put it all together themselves. So multidisciplinary clinics can be a great resource as well for patients.
Thank you. And Dr. Hughes?
Yeah, I'm going to echo a lot of what is said here about getting in to have at least one physician that you really feel like you have a relationship with, that you can trust, so that you can talk about these very important decisions and really pick together what is right for you. In terms of looking for resources and things, I think you can also use the website we're using today, Your Health Matters Today, which has a host of friendly, interactive kind of options for looking at prevention, learning more about prostate cancer itself. And I think it has some prompts even right now about what kinds of questions you can ask your doctor. If you're feeling kind of uncertain what your provider is going to say to you, or want to kind of fact check afterwards if you're not sure you understood, I think for your primary care doctor, you might want to look at the American College of Physicians guidance on whatever the topic is. Those are also broken down both in language for providers as well as for patients to kind of understand what the basis of what you might talk about is coming from.
A lot of great information. Thank you so much for joining us, Dr. Brawley, Dr. DeVille, and Dr. Hughes. Thank you so much for your expertise in answering a lot of questions and giving information that many of us may not have known. And once again, this is Your Health Matters. Take control over prostate cancer. You can go to mymagicdc.com to view this again. Thank you so much for joining us. I'm Vic Jagger with Magic 102.3 and 92.7. Thank you and good night.